That was, so Dr. Dena Jundt, did I pronounce that right? Oh, will be speaking to us today about osteoporosis and Dexa scans. Welcome, Dr. Jundt.
Jundt is a German name. That would be my husband's fault. My maiden name was Brock. It was easy to spell, it was easy to read, and it was easy to pronounce, but that wasn't an option, so Jundt it is. Talking today about osteoporosis, we'll go over some of these objectives in the talk, just why it's important, how we test for it, and what we do about it once we diagnose it. 54 million Americans are estimated to have osteoporosis or osteopenia, and I'll go on to define exactly what that means. But thinning of the bones, that results in 2 million broken bones every year and $19 billion of cost. So it's an important topic for us to know about and hopefully prevent some of the problems. I brought a few models with me. Rachel has those, but here's kind of a zoomed in picture of what the bone looks like normally. The right side is a normal bone, so that's a healthy young adult bone, and we're looking at it with a microscope. So we see a lot of the white calcium and a few of the small holes or pores. The bone's natural shape is a honeycomb, and so as you get osteoporosis, porous bones or thinning of the bones, the honeycomb becomes more pronounced, more holes, less of the bone. When they do that, obviously they lose strength, the structure changes, and so the ability to fracture becomes a lot higher. The bones change with age because the question is why? Why are they thinning in the first place? This is kind of a simplified idea, but I just put it up there to talk about remodeling. You know, throughout your life, the bones are breaking down, rebuilding, and so they're changing. When we're younger, the matrix can keep up with the change and your bones retain strength even though they're still turning over. But with age, they are less productive at rebuilding and better at breaking things down. Normal bone, healthy bone, thinking back to that first picture, lasts until about age 40 in the average healthy person. So bone breakdown keeps pace with bone formation. Then due to a lot of factors that we'll go over in a little bit, the bone breakdown outpaces the growth until we finally get to stage 3, which is where osteoporosis sets in. Rachel has another model there that shows the stages, so you can kind of compare them. Stage 3, your osteoporosis, and then by stage 4, which is pretty profound on that model, the bones are more pores than they are calcium. With stage 2 and 3, you don't really get a symptom. You don't have a pain, you don't have a change in posture. It's not until stage 4, severe, until you start to notice things like chronic pain. Bone pain is a common complaint. Or you see somebody who used to be 5'8" and now maybe they're 5'6", or they walk with a stooped posture. Those are signs when I'm looking at someone that maybe their bones have started to thin, they've lost height in their back. All kinds of factors can speed this up for us. So everyone can look at that list and see something that you could relate this to almost anybody. Most importantly, you know, I'd point out that when we have a woman who's pregnant or breastfeeding, their bones become as osteoporotic as an elderly person, you know, as a stage 4 osteoporosis. They have the ability, though, to rebuild that calcium. You know, after they quit having calcium taken out, they can replenish it and get their bone strength back. Medications play a big role in this. And I put up there the word PPI. If you know what that is, if that's a familiar phrase, that's omeprazole. That's that stomach medicine that we encourage everyone to take for heartburn. Omeprazole affects your ability to absorb calcium. So it's fixing one problem, it's fixing your heartburn, but it's causing a long-term problem of poor calcium absorption. So anytime we're prescribing any of these things, making any of these diagnoses, we're always looking at that. We're balancing back and forth. Does the risk here outweigh the benefit? So based on all of this, we decide who to screen. there on the bottom I put different groups have different ideas of who should we test for osteoporosis. You know, you look at that list of risk factors. And so I put up here the USPSTF task force guideline. So any woman over age 65 or any woman less than 65 who has a high 10-year fracture risk. There's a big calculator we can plug your risk into, but these are the things on the calculator. We're plugging in this information along if they've had a bone density test in the past to decide if they're high risk. Most postmenopausal women with any other risk factor qualify, though, for a Dexa scan. Men, there isn't a guideline, really. The USPSTF doesn't commit to anything, only if they have what they call insufficiency fracture. So that's a fracture that doesn't quite make sense. Maybe a compression fracture in the spine, maybe a ground level fall that results in a really complex fracture. And I would say the other thing that kind of catches us for a man to have a Dexa scan is, let's say they have their knee replaced, and then I get a call back from the surgeon that says their bones are soft, there wasn't good bone to put the replacement into. So then we pursue bone density testing and potentially treatment. This is how we screen. This is a Dexa machine. It's a fancy X-ray machine. You lay down on the bed, and that arm over top of you sends beams through you of X-ray, and the machine measures what goes through. Calcium, the bones are good at reflecting the beams, and the soft bone is not. So they do the scan typically on your hips, your femurs on both sides, the low back, sometimes the wrist. If you've had back surgery, obviously they can't use that spot. If you've had a hip replacement, they can't use that spot. So they kind of move it around to that case. Oops. After you get your Dexa scan, this is what I get back. There's a lot of numbers, there's a lot of math involved. The machine gives us a number and then a radiologist confirms it. Of all of this on the page, and this by the way is off of Google, and there's several pages generally. The only important thing for this talk is that middle number there, the T-score. T-score is kind of based on the standard deviation from the mean, if you can go back to math class, which I do not care to do. But you can see here, this T-score in the spine, I think it says 2.0, and then it did the left and right hip 1.7, 1.9, a median of 1.8, and then the difference 0.2. So based on this, then I decide what's their diagnosis. This T-score, looking at the worst one, it was negative 2.0 from the mean. That gives us a thin bone. So looking at that model, you could call that the level 2 or the stage 2 or stage 3. And so based on that, then we make a recommendation for treatment. For osteopenia, we just have people start calcium and vitamin D. So of course there's conditions where you can't take enough calcium, kidney stones, renal failure. But for most people, about 800 international units of vitamin D every day and about 1,000 of calcium. And this is a number I say over and over all day long. Take your calcium, take your vitamin D. And these recommendations are people younger than 50, older than 50. So take your calcium, take your vitamin D. What if the Dexa scan's worse? This Dexa scan shows a lumbar spine T-score of negative 2.6, negative 2.4 in some places, but overall worse, thinner than the last bones. Then we start prescription treatment. Long list of treatments, lots of different dosing regimens. The top treatments, the bisphosphonates, are generally oral with the exception of reclast. The bottom ones are those infusions people come in and get, or shots that they get. And in addition to this, there's one that's another of the rankle inhibitors that you do every month to try and rebuild bone for a year. The last question is always, but what's wrong? Why aren't we all on these drugs? And there's a whole list of side effects. The most serious one is probably this top one, osteonecrosis of the jaw. So if somebody has bad teeth, we would make them go to the dentist first. We'd skip a treatment if we had to in order to get the dental work done, because any problem in the jaw or with the teeth makes you more prone to having bone death in the jaw, which is a really serious lifelong issue. The second problem there is interesting because it's a fracture, right? We're doing all this to prevent fractures and cost. But if you do fall on your bisphosphonate hard enough to get a fracture, it's more likely to be a very complex fracture. Instead of a nice clean break, we're talking a shattered bone, much more difficult to fix. And then I said osteoporosis, one of the severe symptoms is bone pain. Well, symptom of treatment, bone pain. So we add that to the list. Most people tolerate the treatments really well, especially the newer ones, the injections, as opposed to the tablets, which are a little harder to tolerate. How long do you treat? Well, this is what I found online. Reduced fractures at 4 years in postmenopausal women, but treatment beyond 5 years has an increased reduction in fractures if their T-score is still low, if there's still osteoporosis. But treatment beyond 5 years has no clinical significance, no improvement in mortality. That being said, I would say it's really hard to get off of any of these drugs. Like with any medicine, we like to give it and never take it away. So I'd say until somebody has no benefit from the medication, if it's well tolerated, we continue on forever. All this brings us to the most exciting part. The reason Rachel asked me to give the talk is because we are getting a Dexa scan here in Vermillion at the hospital. Up to this point, at least in recent past, you've had to go to Yankton or to Sanford Sioux Falls in order to get a Dexa scan. Now we'll have this test right here in the hospital. You'll schedule with your doctor. The appointment just takes a few minutes. We get that fancy score sheet back, and then we'll be able to really get the treatment started faster and hopefully prevent more of the problems downstream. And that, of course, the Dakota Hospital Foundation, a huge part in paying for that Dexa machine, and then the Sanford Hospital. So, with that, these are my boys, 10 and 8. They started at the Vermillion School when we moved here 6 months ago. So, and those are all my references. Any questions? Yes.
So, I'm not going to get diagnosed with osteoporosis until I fall and break my bones, right?
You might.
Do you need a Dexa scan to be diagnosed with it?
You do.
That could be cost $5 in routine, or is it something that only you have indications that they would do it?
Yeah, so there's those guidelines. So a woman, it's very easy to get it paid for in the treatment. For a man, we can almost always get the Dexa scan covered by insurance. Any of those risk factors that we mentioned earlier, or a fracture, or a family history. The problem is the treatment. The treatment's terribly expensive, and to get that covered, even with the diagnosis of osteoporosis, is challenging. So we go through insurance and prior authorization, and then it may be that they will approve an older drug, like the tablet, one of the bisphosphonates, alendronate, for example, but not the fanciest, newest, best drug because of cost.
I think my follow-up, you said before about vitamin D and calcium.
Yeah.
Everybody should be doing.
Everybody should be on calcium and vitamin D. Vitamin D we get from the sunshine, we get from our food, but most people don't get enough. And so I think most people, barring some certain health conditions, would benefit from daily vitamin D and calcium. So multivitamin probably has this much in it, 400 of vitamin D. Maybe not as much calcium, but 800 to 1,000 probably. Yes?
Is mortality the correct outcome measure for determining?
Hey, good question. We have to pick something, right? Mortality is there, vertebral fractures, other fractures, but in medicine we measure mortality. And like I said, in practice we leave people on these drugs longer. Yes?
Does the medicine stop it, or just can it reverse it?
Oh, it depends which medicine you pick. The tablet, the old bisphosphonates, they're really good at halting bone loss. The newer medicines, the one I kind of alluded to, Evenity, that you give every month, is good at not only stopping bone loss, but it causes bone growth. And so one of the models that she passed around shows actually the improvement on Evenity from from baseline. So really thin to stronger, although not normal bone, change in bone. And we repeat the bone density after you've been on a treatment, 2 years or 12 months.
So is that a reclass?
Reclass is one of the older drugs. Prevents breakdown, does not rebuild. Yes?
Are there types of vitamin D, calcium, or like the way when you take it that are better for absorption than others, like calcium chews okay, or pills?
Calcium chews are fine. Most of those tablets are better absorbed with acid. So like I said, the acid reducers are good at stopping calcium absorption. The problem is to take a calcium, even a calcium chew on an empty stomach first thing in the morning when your acid is high is really hard on your stomach. So my answer to that is any calcium and vitamin D is better than none. If you want to drink milk, that's a great way to get it. If you want to chew Tums, that's a great way to get it too. Yes?
As I understand it, your family's only been in Vermillion, what, 6 months?
About 6 months, yeah.
Can you tell us a little bit about yourself personally? And how you
Oh, sure. Yeah. I'm from Platte Center, Nebraska. Grew up on a farm there, so that's just north of Columbus. Went to Wayne State College, medical school at University of Nebraska Medical Center. My husband also went to Wayne State College. He's also a physician, and so we went through undergrad, medical school, and residency together. Had our first son in residency, and then went to O'Neill, Nebraska, where we practiced for 10 years. That's a town of 3,000 with a 150-mile reach because there's no other hospitals. So we did everything, all kinds of fun things. And I'd say came to Vermillion for the same type of job where we can kind of do as much of the procedures as we're comfortable doing. But there's just a lot more support, a lot closer help when we need it. So kind of a slow down job. What do I do? Oh, I'm a doctor at Sanford Health. Thank you. Family medicine, obstetrics. I do scopes only when Dr. Quayle doesn't do them. We cover inpatient here. But yeah, a lot of women's health, I'd say, is my main area. Yes?
Now, I had a couple of days ago, three non-medically trained women tell me that it was important to take magnesium with your calcium. It doesn't do anything to take the calcium unless you take the magnesium too. Do I trust their...
Are they here?
No.
Then no.
None of them.
I think it is harmless to take. In fact, it's probably good for sleep. It's magnesium is an important electrolyte, that we all need in our diet. But to take it in addition to your calcium at the time for absorption is not necessary.
Yeah, I'm going to let them keep their opinion.
Yeah. I think that's the safest for all of us.
I'm not going to risk trying to correct them.
Okay. Wise man. Yes?
Is there a difference between the various injectable osteoporosis medications?
Sure.
Like Prolia, Infinity, et cetera?
Yeah. So Prolia, and what's our new one called? We have a bioidentical one that they're changing to. Those are identical. They're really good at stopping bone loss, kind of good at bone growth. Those are every 6 months, an injection, and you get your calcium level typically tested before renal function, perhaps. The Evenity is the best one. It's really good at stopping bone loss, really good at creating bone growth. It's the most expensive one. You have to come in once a month for 12 months straight to get that one. It's an injection, so it's like an in and out procedure, but the drug is very expensive. After the 12 months, then you roll over into the every 6 month Prolia. The Evenity, the every month one, is the one that this little model is from. It's a newer drug, and I think with time, costs will come down, and then it will be the first line. If you ask the drug rep, it should be the first line for everybody. But it's too new for everyone to afford it yet with their insurance.
I've been treated for a while with osteopenia, maybe a little bit of osteoporosis also. I was surprised when the physician who's been treating me said, well, hopefully this one that's coming up will be the last one, and it's been reclassed.
Okay.
I was surprised. I kind of expected that was going to be a lifetime
Yeah.
thing. Is that unrealistic on my part, or what's the deal?
For this to be the last dose, is that what you
Yes.
mean? Yeah, I think that is based on the recommendation. Probably they've rechecked your bone density to make sure that you're stable or improved. And so that's by the guideline, yep, to stop it after 5 years.
Okay, thank you.
Okay, seeing no more questions.
You have one assignment to do. We do a 50-50 drawing, so we have little blue buckets that they put money in each one every week.
The hardest part.
The hardest part, yeah.